a different way of dealing with this. Okay, you've got to use GnRH and several other remedies for this thing. Now, Ruta, did you get the idea that when you see this, you know instinctively that this is unopposed? This endometrium has been acted on by unopposed estrogen, and I hope everybody gets this picture. Okay, there is no simple hyperplasia on the right hand side, Ruta. Okay. All right.
Yes, ma'am.
So this is an atypical endometrial proliferation driven by unopposed estrogen stimulation. It is indistinguishable from AHEIN. And if we don't have the myometrium, which we are not likely to get because this is you can't do a TCR, it could also be a well-differentiated endometrial carcinoma. There may be, because you can't tell the difference between EIM and WEC in most of these curatives. Okay? And then you say that many such proliferations in young women are reversible by appropriate hormonal manipulation, and you ask whether the patient has a PCOS. Now here, who's going to read this history? Let's see. Anybody wants to volunteer?
40-year female.
Right. Who's that?
Bhavna.
Bhavna, good.
40-year-old female, late marriage, a long history of irregular periods with infrequent bouts of heavy bleeding, never sought a gynecological opinion till desirous of conception. USG showed polycystic ovaries, thick endometrium, no myometrium.
Good. Now come on, Bhavna. Now this is not difficult, right?
Yes, ma'am. Here I can see there is in the first picture.
I just want what you are going to write, because describing this is fine. We will keep. Papillary, and it shows mitoses and tall columnar and all this. Okay, but what are you seeing?
There is, ma'am, proliferation of the glands in this. I can see with increased gland and there is increased gland and stromal ratio, and here I can see some papillary enfoldings also. So I feel there is hyperplasia, but it is
there is more than hyperplasia. No, where is the glandular? Where is the stoma?
Stoma is very scant in this, ma'am.
Okay, and there is papillation.
Yes, ma'am. Papillary projections are there within this.
So, and there is metaplasia as well. You can see, right?
Yes, ma'am. Here I feel there is metaplasia also, mucinous.
So, but these glands are not round like you saw in the others, nor are they branched in the usual
kind of.
Exactly. Yes.
I can see, and there I feel some cytoplasmic this mucin, some cilia I can see over the cytoplasm.
Snouts, no? I think
not apical snouts I can see.
Okay, yeah. All right. So what would you have called this? Now I'll just ask you. If this was a 60-year-old woman, what would you call it?
60-year female, ma'am. Then
suppose this woman was 60. Now she's not 60. She's 40 or something. If she was 60, what would you call it? Bhavna, if this lady was 60 years old and this was her endometrium, what would you call it?
Atypical hyperplasia, ma'am.
In a 60-year-old woman, you're going to call it atypical hyperplasia. Why? Why?
Ma'am, it can be endometrial.
So can be. You think you were going to say that this is not endometrial carcinoma? Of course, it looks like endometrial carcinoma. I don't think that we would wait to call this atypical hyperplasia, would we? No. But now this woman is not 60, she's 40. And this is a cycling endometrium. In the sense that she's got irregular periods with infrequent bouts of heavy bleeding, etc. So this is a cycling endometrium. It's very hard to get an endometrial carcinoma in a cycling endometrium, right? Yes. So, and she has polycystic ovaries. So what do you think she has? Again? Come on, Bhavna.
Suppose this estrogen, ma'am, in this case.
So there is estrogen in the system and there is no progesterone, right?
Yes, ma'am.
Once again, this is another pattern of atypical endometrial proliferation. Unopposed estrogen stimulation. Okay, and again, it is indistinguishable. If this was an elderly lady, I don't think we would have any problem calling it a well-differentiated endometrial carcinoma. But this woman has got polycystic ovary. She is a PCOS, and therefore she was put on GnRH analogs. And you want to see what is her endometrial biopsy after 4 months of GnRH analogs?
Yes, ma'am. That revert back. We don't have that increased in gland and stromal ratio. It has come back to the normal.
Absolutely. Once again, I will draw your attention to the endometrial lining. Nobody should forget this endometrial lining. So and this looks like a rest endometrium, does it or does it not? It is not yet in the mid-proliferative phase or anything like that. This endometrium has gone to sleep. Why? Because the GnRH is not stimulating the pituitary to produce FSH and all that sort of cycle. So for all practical purposes, this has gone to a resting stage because you are preventing the pituitary ovarian hypothalamic pituitary ovarian axis from being stimulated. Okay, that's what GnRH agonist therapy does. All right, now there are some iatrogenic effects. You can get iatrogenic progestationalization, tamoxifen effects. This is, what would you call this, Ananya? Ananya there?
Yes, ma'am.
Good, Ananya. What are you seeing? Is there estrogen in the system?
No, ma'am.
No, ma'am. What's in the system?
It's desensitization is present, ma'am.
I know, but what is in the system? If it is not estrogen, there are only 2 hormones that you have to remember. Not HCG and all that stuff is not relevant here. So what are the 2 hormones that we should be thinking of when we are looking at an endometrium?
Estrogen and progesterone.
All right. So what is this effect that you're seeing of it?
Progesterone effect.
How do you know that?
Because that deserialization changes we can make out now.
Right, we can see deserialization.
And the glands are not proliferating and no mitosis are also present.
All right.
It looks inactive glands.
Understood. But are these the sort of glands that you expect to see in a normal
No, ma'am.
normal secretory phase. So you're telling me that there is progesterone. Excellent. And you said that. Why? Because there is desensitization and there are spiral.
Yes, ma'am.
Yes,
Yes,
so
ma'am.
there are spinal arterioles, and you can see that. Here are the spinal arterioles.
Maybe because of exogenous progesterone pill endometrium.
Because of exogenous. But why do you say that it is exogenous? Why? Why do you say that this is exogenous? These are the what is the nature of these the glands? When you see the glands, Ananya, what kind of contours do these glands have?
Inactive glands, ma'am.
Sorry, they're inactive.
Inactive.
They're inactive.
And they're
Which
curved
means
and
they're not
dilated.
proliferative. Very good. That's what progesterone has done, right? It has made them inactive. But you see the shape of these glands?
Yes, ma'am.
Yes. What are
Curved
they like?
and dilated.
Sorry. Look at these. You don't see the glands here.
Angulated glands.
Angulated, branching, cystic. Do you see it or not?
Yes, ma'am.
Yeah. So how do the glands become angulated, branching, and cystic? So what message do you take from this? Huh? Why is there? You see the cystic gland or not?
Yes, ma'am. Cystically dilated glands are present.
Why? Why are these glands cystically dilated?
Estrogen is not there.
Sorry.
Estrogen is not there.
Because its estrogen is not there. That's why they are cystic. Now hear yourself, Ananya, please. Huh? Bhavna?
Yes, ma'am.
Why are these glands cystic? Why are they branched?
Because of in secretory phase.
Because they're secretory.
They are not secretory, ma'am. They are actually inactive looking because this is cystically dilated, and then we have
Alright,
this
but
branching also.
just because there is progesterone in the system, it makes the gland cystic? The answer is no.
No.
So the glands had to be branched and cystic before progesterone acted on it. You think so?
Yes, ma'am.
Yes, because progesterone cannot make the glands cystic. Progesterone cannot make the glands branched because it has no proliferative activity at all. Do you realize this now? Only estrogen can do something, can make glands proliferate. Do you agree?
Yes.
Yes. So if there is cysts, then we know that estrogen, when there is excessive estrogen or prolonged unopposed estrogen in the system, you can get disordered proliferation, cystic change, and EIN, right? Yeah. So now what is the message that you're getting from here, Ananya? Come on. That there is progesterone now is obvious. But before progesterone came into this system, what happened to this patient?
Estrogen. Estrogen is not there.
Estrogen was not there.
Was.
Oh, it was there, and it was abnormally there. Otherwise, you could not get cysts and you could not get branching. See, this is how we have to, the endometrium should talk to you. And the endometrium can talk to you only in these two ways. Is there estrogen alone? Is there estrogen? Was there estrogen? And now there is progesterone. Okay? Or is there only progesterone? So now what do you want to say about this? Because you've got cysts, because you've got branching, it means that there was estrogen. Not only was there estrogen, this was abnormal. Because otherwise you can't get cysts, right? In a normal cycling endometrium, you get cysts. Do you?
No, ma'am.
No. So that means there had been estrogen. That patient has now been, progesterone has come into the system, but progesterone cannot just come into the system like that because there was unopposed estrogen before. So where is that progesterone going to come from? Where is it going to come from, Ananya? From the gynecologist. No, the gynecologist has given this patient progesterone to stop.
Hormone replacement therapy.
It's not hormone replacement therapy. This is unopposed estrogen. She was bleeding from an unopposed estrogen, and to convert this unopposed estrogen to stop her bleeding, the gynecologist has given her progesterone. So this is iatrogenically progestationalized endometrium. Yeah, so there you are. It's iatrogenic progesterone acting on an endometrium, which showed, okay, you can see it in the remnants of that simple disordered proliferation. That is hyperplasia without atypia. You can see the outlines of this disordered proliferation. Look at them. You can see this in the branching, in the cystic. You would never see this unless there was this sort of endometrial effect, which was unopposed estrogen acting on this endometrium. The gynecologist, on top of that, added progesterone and converted this endometrium. You see, the glands have got differentiated in the sense that they are quiet, they are not proliferating, but you can't change the shape of the glands, right? Then they were cystic, they were branched. Progesterone can't do anything to the original nature of these glands except to induce differentiation, to cut off the proliferation, and to make the stroma decidualized. Have you got what I'm trying to say?
Yes, ma'am.
Yes. And I tell you, if you guys just think of the endometrium in terms of what the hormones are doing to it, you will have no problems at all. Okay. Now, these are tamoxifen effects. What you often get is a very atrophic glands because it's an anti-estrogen, but tamoxifen has got a dual effect on the endometrium and it can be proliferative as well. So don't be surprised that you can see all kinds of hypoplastic effects with tamoxifen. It has, in the breast, it does not produce proliferation. It is an anti-estrogen. It is also an anti-estrogen here, but in some endometria, it might actually produce proliferation. All right, now let's talk about endometrial polyps. This is an endometrial polyp in a perimenopausal woman. Okay, anybody wants to say what this is showing? Who wants to take this now? Aishwarya?
There is
How do
endometrial
you
line.
think it's a polyp?
It
How do you know
could
it's a
be,
polyp?
ideally, polyp is described by lining epithelium on three sides of the fragment.
Okay.
If it is not sampled properly, it could just have epithelium on one side also. Part of the polyp can have
This
just
is all terribly theoretical, you never see it. Okay? That's all theoretical, you read it in the books. But what are you seeing over here?
There is a lining epithelium, and it has the core of the polyp has cystically dilated glands, and there are thickened vessels also.
Yeah, you can see that, no? Yeah, you can see. So it is a genuine polyp. Here is the
Yes, ma'am.
thickened vessels. You can see that. Yeah, you can see the thickened vessels, and then you see the high part. What does the high part tell you about this polyp? Again, think about it in terms of what are the hormones in the system. Benign endometrial polyp is what we normally write. But
Yes.
tell me why there is a polyp. What is going on in those glands and in the stroma?
Looks more like proliferation.
Proliferation. It looks more like proliferation. Is it proliferation or is it not proliferation?
Mm,
Come on, Aishwarya. What do you need to say that there is proliferation?
There should be increase in glands. Mitosis should be there.
Increase in glands. Okay.
No,
Uh,
this is not proliferation.
It's not proliferation. It most certainly is. Why? Because there is stratification of nuclei. If you look carefully, I mean, I don't need to blow this up, but you can see that there are. Let me see if I can get a thing to annotate. 1 second. Okay. Can you not see that there are these little dots? I covered one of those dots, but you can see lots of dots in that lining epithelium. What are dots in the lining epithelium of a gland?
Mitosis
Oh,
probably.
it is mitosis. There's nothing else that produces these dots. Okay, so this gland is in mitosis. Okay, and you look now at other glands here, you see them in mitosis. Not only that, you see irregular looking glands. Can you see them or not? They're dilated, etc. So what do you think?
Effect of estrogen.
Is the effect of estrogen? Excellent. Well, is there any progesterone?
No.
No. So this is a polyp which is showing the effects of unopposed
Estrogen.
estrogen. Very good. And many of these are cystically dilated and very atrophic looking. So this perimenopausal woman is probably now going to become menopausal anytime soon. So it's like a cystically dilated atrophic endometrium, but there is estrogen acting on this. This is not atrophic, so that there is no estrogen here. And then when you ask, you'll probably find that this woman is a little on the obese side. So she's having problems going into full menopause. Okay, now that we're sorry. So let us go to the next. Why am I not here? Yes, okay. Now here this is, I'm just going to tell you this because it's important, okay? Very often we just look at polyps and say benign endometrial polyp. It's becoming more and more important to do a P53 on the so-called benign endometrial polyps in postmenopausal women. Okay, when you do a P53, you will suddenly see a P53 signature when you may not have even suspected it. As you can see on the left-hand side, this is from a paper by McClovic, and you can see that you don't suspect anything. On this side, you do a P53 and you see a signature there. Not only in the glands, you also see the P16, you see it in the superficial lining epithelium, and one has to be very careful. These days, when I get an endometrial polyp in a postmenopausal woman or a perimenopausal woman, I like to do a P53. Okay, and here is an endometrial, it presents as a polyp in a menopausal endometrium. Here, at least you can see that the glands are atypical. There is cytological atypia. Okay, but it doesn't look like an endometrioid type of carcinoma. And when you do a P53, you see that this is, you might wish to call it an EIC as long as it is confined to the endometrium and it is not in the myometrium. But this is not good news for the patient. This patient cannot hang around. This patient requires hysterectomy and staging and all the rest of it, because it's quite possible that this patient has lymph nodes that are positive or spread beyond the uterus, because this is not a good disease. All right. Okay. Now here is sometimes you do frozen sections on an endometrium, and many people send us frozen sections before they're going to do a hysterectomy because they want to know, is there anything there that's abnormal, and should they be doing a node dissection, for instance. Okay, and here is a frozen section, and it shows an atypical hyperplasia with squamous metaplasia. Or how do I know whether this is a TNC, whether there is a well-differentiated carcinoma, which will be seen when the uterus comes out with squamous metaplasia. Okay, so I don't think that we can know, but this is what happened after we got the hysterectomy. This is, you might say it's a carcinoma, but it isn't, because it was not infiltrating the myometrium. It was an AH or EIN, and there was no evidence of myometrial invasion. So these are some of the problems that you have in frozen sections. You can't always tell them, you know that it's abnormal, you know that it is at least an EIN, whether it is a well-differentiated endometrial carcinoma with myometrial invasion. If we don't have a TCR, which shows you the myometrium, you may not be able to tell. Okay, so now let's get to the meat of the thing: how to report on an endometrial sample. If it is scanty, please say that it is scanty and just note the presence of cervical tissue or whatever. Premenopausal, you have to say the phase if it is benign, another cycling endometrium. All right. Exact dating is obsolete. I've said it many times. The abnormality should be stated, I stated, in terms of hormonal action. Even if you don't want to do it, think about it in terms of hormonal action. Like disordered proliferation, suggesting unopposed estrogen activity. If there's metaplasia, please say it. Pregnancy associated changes, of course. Please don't say pseudodecidua and predecidua and all of that. It's not possible to tell decidua from pseudodecidua, etc. It's better to use degrees of progestationalization instead, that this is heavily progestationalized or not progestationalized. And if there are iatrogenic effects, then say the name of the drug. All right. Now, come on. We'll have a few questions over here. Let's start with Bhavna. This is an endometrium. You have these three choices. Pick. Is this an 18-year-old woman? Is it a 35-year-old woman? Is it a 60-year-old woman? Come on, Bhavna. If you don't do it in 1 minute, we go to the next. Mansi, 1 minute.
Yes,
2
ma'am.
seconds. Yes. 10 seconds, Mansi. Choose. Okay, Ria, 10 seconds.
I'm 60-year-old.
60-year-old. Ria, you're absolutely right. Why, Ria?
Because the endometrial lining is present very close to the stratum basal with the inactive glands that are present, along with cystically dilated atrophic glands as well.
That's excellent, Ria. So this is 60 years old. So now, Ria, will you answer this because you answered that? 10 seconds. Is this low estrogen, high estrogen, or progesterone in the system?
Low estrogen.
Low estrogen. Excellent, Ria. Okay. So this is cystic atrophy of the endometrium. All right. Now here we are. The next person on the list, Aishwarya. Quickly, 10 seconds. You have only two choices: cycling endometrium, non-cycling endometrium. Cycling endometrium. Why did you say it is cycling endometrium? Why? Huh? There are two choices, so you're either right or wrong. So now since you picked this, you'll have to tell me why.
This destabilization and the
That's
gland.
what, sorry? Come on.
The gland, there is so much showing destabilization and.
Stroma is showing decidualization. Wow. Really? That is terrible. You picked the wrong thing for the wrong reason.
There is proliferation, there's mitosis seen. So.
And so how can you say that there's decidualization? Huh?
Sorry.
Sorry, yes, you have to say sorry to yourself. Come on. You said cycling, now tell me why. What is the alternative? Non-cycling endometrium. What is a non-cycling endometrium, please?
Non-cycling endometrium, there is.
Postmenopausal, right?
Yes, ma'am.
So now tell me, is this postmenopausal endometrium?
No.
Why?
Because the basalis is not close to the
There is no
lining
basalis.
epithelium.
Absolutely right. You have got an endometrial lining and you have glands which are proliferating. That means it is not greatly proliferated, but you can see the mitotic figures, yes. In the basalis, by and large, you don't get mitotic figures. Huh? So that is why this is a cycling endometrium. All right. Come on now. You have to answer the next question. Is this low estrogen, high estrogen, progesterone, OC pill? What? Low estrogen, pick no one. Come on, quickly. Aishwarya. Now 10 seconds. If you haven't done it in 10 seconds, let's ask Ruta.
Low estrogen.
Low estrogen. Yes. Why did you say that, Ruta? You're right. It is a resting early proliferative endometrium, but why did you say low estrogen?
Because there is no effects of, there's no increased proliferation and.
Yeah, because the glands are few, the stroma is not proliferating. You can't see anything. So this must be some early low estrogen phase. Now, once the FSH comes into this whole thing, then there will be estradiol being produced by the ovary and everything will be fine. All right. Come on now. Next person. Who's that? Ruta, you finished. Okay. This is Ananya. Come on, just tell me. Low estrogen, high estrogen, OC pill.
Low estrogen, ma'am.
Low estrogen. Why?
OC pill endometrium.
Now you make up your mind now. You can't tell me then it is high estrogen. Is it high estrogen?
No.
No. Very good. What are you seeing in the stroma?
Decidualization.
Right. Decidualization and very, very dead glands, right? So glands are dead. They're not showing any activity. And there is a decidualization of the stroma. There are very few glands as well. So this has to be OC pill endometrium. It's not just plain and simple low estrogen. You just saw what the low estrogen was like. Resting cycling low estrogen endometrium. And this is not, this is not an atrophic endometrium. Okay, because you've got decidualization over there, which is obviously iatrogenic. Okay, good. Now we come round full circle. Bhavna.
Yes, ma'am.
Pick.
High estrogen, ma'am.
High
Because of this high proliferation of these glands.
Exactly. It is unopposed estrogen with simple hyperplasia. You can call it disordered proliferation. Excellent. Now, since you answered that, now you get the chance to answer the next one. 10 seconds. What do you think this is? An ovulatory cycle of 28 days, an ovulatory cycle of 36 days, 3 years postmenopausal, or any of the above? Choose. Quickly, Bhavna. Quickly. Acha, Bhavna's taking long, so Mansi.
Any of the above.
Any of the above. That's right. Because an atrophic endometrium, if there is obesity and it is producing estrone, by the way, there are 3 kinds of estrogen. Number 1 is the normal estrogen that we all have during the reproductive age group, women have. It's being produced by the follicle, that is estradiol. Okay. The placenta produces estrogen, and that is known as estriol. And the fat produces estrogen, which is called estrone. And the most ineffective or very poor stimulation of the endometrium of the target organs is by estrone. Okay. It takes a long time for the endometrium to react, and that's why a patient with obesity can go on for several years postmenopausal and suddenly she will bleed. Okay, and you may get this kind of endometrium in a postmenopausal woman, or this may be a cycling endometrium where you get 28 days, 36 days, maybe 40 days, or whatever. Okay, I'm glad. I think you're getting the idea. Now, if this was postmenopausal, Mansi, since you answered, what do you think? She's 80 years old, she's obese, she's on blood thinners, or none of the above?
Obese.
She's obese. Excellent. See, you guys are very smart now. I'm so glad. Now, here's an endometrium. Who's next after Mansi? Priya.
High estrogen.
High estrogen. Excellent. So, is this a 36-year-old with PCOD? Is it a 56-year-old on HRT? Is it a 40-year-old obese person, or all of the above?
It can be all of the above.
Excellent. See now how you guys have got the hint. Yes, this is unopposed estrogen. It's AH or EIN, and all of these patients can show that kind of thing. All right. So that was about how to report on premenopausal. You call it disordered proliferation, etc., etc. Use the WHO 2014, hasn't changed to 2018. In young women with atypical proliferations, when I say young, they are in the late 20s, 30s, or even early 40s. You should not call these things carcinomas without qualifying it and say that it is usually driven by unopposed estrogen and may revert with appropriate hormonal manipulation. I've seen too many young women who have lost their uteri when they need not have. Okay, so it's not one line bald report that you have to write, and that's why please think of the endometrium as a target organ. Think of it as whether there is estrogen in the system, is there progesterone in the system, and has progesterone acted on a well estrogenized endometrium. Okay, so polyps and all that. Right, now come on, these are postmenopausal women. Who was the last one? Aishwarya. Now Ruta, tell me, what would you call this? She's postmenopausal.
Probably she's on this thing.
Okay.
HRT, because she had estrogen in her system and now she has progesterone also.
She's got progesterone. Where's the progesterone? I can see the estrogen. I will agree with the estrogen. Okay, I can see that there are probably some proliferating things. Yes, and she must have had some bleeding. Otherwise, why would anybody go to do or get a biopsy from a postmenopausal? Okay, but you think it's benign? Ruta, you would have called it benign endometrial polyp, correct? And here is where I tell you that you must. I do it. This would have gone off as being benign. Do you see that lining epithelium? You can see the lining epithelium there, a bit of it. This has got a P53 signature. Yes. On the right hand side, that is this is P53. On this side, it's progesterone. Okay. So progesterone in the system is showing you that the one with the P53 signature is progesterone negative, but the normal glands are progesterone positive. Progesterone doesn't mean that there is progesterone in the system. It just is a way of saying that these are normal glands. You know, you look for estrogen or progesterone receptors. So there are receptors over there. So that is PR or PTR, and this is P53. So however deceptively benign postmenopausal endometrium looks like, do not just write it off as that without thinking at least about EIC. All right, here is an endometrial polyp in a 78-year-old female. Now, who was that? Who has finished? Ananya? What is this? Ananya?
Yes, ma'am.
Quickly, 10 seconds. You know, we have sat here for almost 3 hours just doing normal or non-neoplastic endometrium. And if I got something through to you guys, I will be happy. Yeah. What is this? What do you want to say?
So no.
Sorry?
Glands are cystically dilated.
Very good. And this is a 78-year-old female. So, and they're all very flat looking, no? There's no proliferation, but they're cystically dilated. And you know that there is a condition.
Senile cystic atrophy.
All right, senile cystic atrophy of the endometrium. Yeah, but you know what? No, I always do a P53.
Okay.
There is no P53 in the system at all. And this is, yes. So this is P53. Yeah, mutant type, and therefore this is EIC. All right. Now, last is Bhavna. Come on.
Yes.
Tell me. Tell me what the story is in this patient. This is obviously a
Postmenopausal women.
Yes, okay. And it's a hysterectomy.
Okay, ma'am.
Yeah, you can see that. No, it is a
Yes,
hysterectomy.
it's
Yeah,
hysterectomy
it's
specimen.
postmenopausal. Why do you say it's postmenopausal?
History is.
Because the history is postmenopausal. Shame on you. Huh?
And then we have these
What do you have?
glands.
What is this?
This is the lining epithelium of the endometrium.
There's no lining epithelium ko kate mein jao. Huh. So
And then we have these
epithelium. Here is the endomyometrial.
Endomyometrial junction.
And what do you have? Some few glands. No, so this
Few
is
glands only are there.
trophic endometrium. Yeah, it looks like that. It's what you expect, a thin endometrium in a postmenopausal woman. Very good. Then,
Uh,
and I'm showing you these glands at little higher power. What you're seeing over here is in higher power. What do you see?
These glands are dilated, ma'am. And here I can see the mitosis also.
So there is some estrogen, no, acting
Yes,
on
ma'am,
this.
estrogen
Otherwise, in a
effect is there.
postmenopausal woman, you should not see some proliferation. And it's a weak estrogen that is acting on
Estrogen
this.
effect.
Yes, weak estrogen effect in an endometrium that is postmenopausal. Then what has happened?
And
What's
in,
the next picture?
here we have this increasing gland to stroma ratio, back-to-back glands we have here.
Very good. So what is that? What is that?
Hyperplasia, ma'am.
Hypoplasia with back-to-back glands. So which kind of hypoplasia?
Atypical hyperplasia.
So it is EIN, no? Just see, I've shown you a
Yes,
picture. There's no stroma in
There
between.
is no stroma in between these glands, ma'am.
Excellent. And what do we see in the last picture? This must be.
This is the higher power of the. This is P53.
So how do you interpret that?
There are ma'am, a few of the cells which are showing this nuclear positivity, but mostly it is negative.
So what does it mean?
Wild type of
Mutant or is it not?
not mutant, ma'am.
It's not, because when you get patchy focal P53 expression, it has to be dense and diffuse. Okay, so this is normal P53 expression. So there is no, it's wild type, in other words, non-mutant. So what do we need to say? So that is an atrophic endometrium with some estrogen acting on that. This is an EIN, and this is P53 wild type expression. Okay, so in a postmenopausal lady, you talk about atrophy with or without cystic change and or estrogenic effects. Okay, beware the EIC, which is different from EIN. I hope you all get it. EIC is endometrial in situ carcinoma. EIN is what, Bhavna?
Endometrial intraepithelial carcinoma, ma'am.
Neoplasia. Okay, that's EIN. EIC is something else that is related to a serous carcinoma of the endometrium. So please use P53 staining if you have it, if possible. Don't get terribly worked up. As Dr. Bhupesh said, that 99 or 98% of polyps in postmenopausal women are absolutely benign. You may not be able to, unless you do a whole series and you stain all the postmenopausal women, you may not get the percentage in your particular practice of mutant P53, but it's something that I feel that some medical college should do, so that you know what is the your incidence. Polyps, you have to say same as above, mention metaplasias if any hyperplastic endometrium, which is usually estrogen driven, and please don't use the term phase, so you can't get a proliferative phase in a postmenopausal endometrium. Okay, and you comment about the source. If you think that there is endometrium in a postmenopausal woman's system, then you say that this could be due to exogenous sources like HRT, dietary. You know which dietary source gives you estrogen? Mansi? Dietary source? If any of you are meat eaters, nowadays they feed cattle and all that with estrogens. Yeah, or phytoestrogens. Soya is full of phytoestrogens. So some people who think that they're dieting away by eating soya may be just loading their system with phytoestrogens. Or if it's endogenous, it could be obesity or an ovarian stromal tumor, other endocrine disorders as well. Now, of course, you get all of this in postmenopausal, but I'm not talking about that. So now I think we've come to the end. I managed to finish exactly before 10 o'clock. Otherwise, you would have all gone hungry. All right. So thank you very much for everything, and more than anything else, let me stop sharing.
It was very informative, elaborate, very informative, and very interesting slides. They look simple, but so much information from each slide.
Well, I'm glad. I don't know. I don't think that there are any questions in the chat box. But if there are
questions, should I take?
Are there chat questions? What questions can there be in the chat box?
Like, it's not very. Some of the questions have been answered, like during
three types of estrogen somebody wanted to know. Estradiol, which is the main estrogen that comes from the follicle, which is being stimulated by FSH. Then there is estriol, which comes from the placenta. So if you're not pregnant, you can't have estriol, but you can have the third type of progesterone, third type of estrogen, which is called estro, which is produced by your fat. Okay, and you can have both. If you're fat and you're still cycling, you will have both estradiol and estro. Okay, so I don't think that there are too many.
In some, like something like what's the difference between how can you differentiate between endogenous and exogenous hormones on endometrium?
No, you can't. You can't do that except by looking at the, like I told you, when you see that there has been some disordered proliferation in the endometrium, and you saw that case, all right, and then a progestational effect, and the the estrogenic effects are still there in the shape of the glands and the dilatation, etc., which you can't get otherwise. This has happened because of estrogen. On top of that has come progesterone. Now, progesterone cannot suddenly come up from an anovulatory, so there's been unopposed estrogen. Now you can't suddenly start ovulating and progesterone come into the system. So common sense tells you that this is come from outside. So it is an iatrogenic addition of progesterone. I see some. So I hope it is making sense to you. All right. Is there anybody else who's
Mostly regarding like inadequate biopsies, like they've been complaints about in the department such things. So I think
sorry, complaints about what?
inadequate biopsies, like how commonly of conception in endometrial curetings or AUP in this era when USG and urine pregnancy tests are already an important part of pre-biopsy workup.
Well, I can't answer that question because I'm not working in a general hospital. But the person who's asked the question is right in the sense that unless somebody, and that was one of the comments I made to Dr. Bhupesh, that a practice in a hospital setting in tertiary care centers can be quite different from practice in the community. How often do you get it? It's how often do you suspect it? So you have a perimenopausal woman whose periods have been up and down and so on, and she's 48, and she hasn't been bothering with contraception. Once in a way, she's got a heavy bleeding, and somebody does a DNC or takes out the uterus, and you're surprised because what is she's got an abortion. Okay, so that happens because you're not expecting somebody at the age of 48 to have a pregnancy. That's our problem, not hers. So that happens. But if you've done an ultrasound, and most people, even gynecologists nowadays, tend to get an ultrasound, then you will not miss the products of conception.
And if out of 10 endometrial biopsies are curating, we see only cervical mucus and ectoendocervical epithelium with blood. In 5 to 6 of these specimens in a teaching PG institution, what do we find it out as?
Sorry, Veena, I didn't hear all of it. I'm just trying to see if I can see it.
Isn't that like towards the initial part?
Oh, initial part. Okay.
Yes. So there are 10 endometrial curatings coming, out of which 5 to 6. Issue, and so how to sign it out, like, because
You see the cervical tissue, you mention it and say that's benign.
Because she's saying that the gynecologists are not very happy, like giving the term inadequate, like such kind of a biopsy.
So I don't think that you should say that it is inadequate. You have to say that it is inadequate. Suggests that the gynecologist has not yeah. So you describe what you're seeing, that there are scanty endometrial tissue. Use the word inadequate. You can say scanty, and you can describe what you're seeing.
If they see only 2 to 3 glands in stroma, OBG department do not want the term inadequate for reporting to be written, or the line kindly report.
Don't say it's inadequate, but just say that it is scanty, and describe what you're seeing. Do you think it's estrogenized? Do you think that you can make some diagnosis on it? But look for the superficial lining epithelium. If you're seeing the superficial lining epithelium and you're seeing a part of the functionalis, however inadequate it is, you think it's inadequate, just report on it. No, I understand that why they're doing that. DNC is always a matter of to be found out. No, why did they do the DNC in the first place?
Yes, and there's one more question, I think, is how to differentiate between disordered proliferation endometrium and endometrial hyperplasia while reporting on H&E slides.
It's the same thing. Endometrial hyperplasia and disordered proliferation is the same. Okay, when you get these abnormal looking, if you're getting a normal cycling proliferative endometrium, then it's a cycling proliferative endometrium where the glands are all nice and round and everything. But the glands start to look abnormal and they're branched and they are, the stroma is in between. So you see, I showed you all of those. You call that disordered proliferation or call it hyperplasia without atypia, it doesn't matter. But I would only say that if you're deciding to use a term and you are working with the same set of obstetricians and gynecologists, please use one term so that there is no confusion about what it is. Okay?
Yes, I think there's one more question. Should P53 be performed on all postmenopausal endometrial biopsies uniformly?
I cannot make recommendations, but I do. Okay? Because I feel that we will sort of miss out on some patients who have EIC in that endometrium, however small that focus is. it's like everybody talks about stick. I'm sure if I asked all the postgraduates what is stick, they will tell me, no, that it is intraepithelial carcinoma in the tube. So this is exactly the same thing. It is, except that it is in the endometrium, and it's a different kind of serous. This is another thing you have to understand. Okay, there is WT1 and P53 and P16 in the fallopian tube. In the endometrium, you don't get WT1 because serous carcinoma of the endometrium is not related to serous carcinoma of the fallopian tube. Just remember that. Get it once in a blue moon. Yes, if you have a tubal carcinoma which colonizes the surface of the endometrium, yes, it might be WT1 positive, but otherwise you have to understand the difference between serous carcinoma of the endometrium and serous carcinoma of the ovary and fallopian tubes. It's a different disease altogether. Okay, so go and look it up. I'm not talking about carcinoma here, but if you do a WT1 on whatever I showed you as EIC, it'll be negative.
There are a lot of attendees thanking you.
They're thanking me. Yes, I know. They should be not thanking me for keeping them so long. Okay. All right. Anyway, somebody's talked about is the gland stromal ratio 1:1 and simple hyperplasia 3:1. I don't like to sort of get into this 1:1 and 3:1 and all that sort of thing because it is never the same from one endometrium to the next. Just if you don't see anything and it is really back to back, that's when I think that you've got atypical hyperplasia. Yeah. Okay.
Okay, thank you, Dr.
Now I just hope that this made some sense.